Symptoms like these have not been observed with this frequency or intensity since then. This was obviously a psychopathological phenomenon. Nowadays, 80 years later, research focuses on impaired motor function of unequivocally organic origin. CNS-related dyskinesias display characteristic features according to the clinical picture. What is known as the extrapyramidal syndrome is caused by damage to the basal ganglia, the centers of the extrapyramidal motor system. Complex neuronal loops form links between the core areas. Various factors can affect the regulation of these functions, giving rise to motor disorders. Certain types of medication are also responsible for motor dysfunctions, especially neuroleptics. Neuroleptics are an integral part of a physician's armory, used both in intensive care and in the doctor's office. In diagnostic interventions, neuroleptics are used for their sedating effect. Used as painkillers, they provide relief in complaints such as shingles and phantom limb pain. However, the classic domain of neuroleptics is the treatment of psychoses. After an acute episode, the neuroleptic shields the disintegrating ego from the outside world, preventing excessive outbursts of emotion. The site of action for neuroleptics are the cerebral synapses. It is the neurotransmitters, dopamine, acetylcholine, noradrenaline, histamine, and serotonin in particular, which are inhibited temporarily by neuroleptics. The extent and pattern of inhibition vary widely from neuroleptic to neuroleptic, which accounts for the different modes of action and side effects within this class of medicines. All neuroleptics, however, are dopamine antagonists. Circulating dopamine docks at specific receptors on the postsynaptic neuron. When neuroleptics occupy these receptors, the effect of dopamine is blocked. For a long time, the dopamine receptors were classified merely as D1 and D2 receptors. These receptor subtypes have different amino acid sequences, locations, and pharmacological properties. Today we know that both these receptor types belong to entire receptor families of their own. Neuroleptics bind in various ways to these receptors. Some display an affinity for D1 receptors, while others, like clozapine, have a greater affinity for D4 receptors. Most classic neuroleptics, however, display affinity for the D2 and D3 types of receptor. Blocking of the dopamine receptors in the limbic system is responsible for the antipsychotic effect of neuroleptics. When the dopamine effect is also inhibited in the extrapyramidal system, motor disorders are to be expected. Clinically, these effects manifest as the extrapyramidal syndrome. 4 types of motor disorders are seen in patients receiving neuroleptic therapy. Anomalous posture and movements, especially in elderly patients, as symptoms of the Parkinsonian syndrome. Other patients are unable to sit or stand still. This is known as akathisia after administration of neuroleptics. Although less common, there is a third form of reaction manifesting as increased muscular tone of certain groups of muscles. This severe dystonic reaction is also called acute dystonia. A much dreaded side effect of neuroleptic treatment is tardive dyskinesia. Patients suffering from this complaint display bizarre hyperkinesias such as writhing and choreiform movements. The hyperkinesia affects the mouth, tongue, cheeks, and jaw muscles in particular. Normally, dyskinesias are not as pronounced as this until after several months or even years of neuroleptic therapy. The tongue constantly twists and turns, making even chameleon-like movements. Another early symptom, apart from the characteristic tongue movement, is a rhythmic bending and stretching of the fingers, as if playing the piano. Such hyperkinesias can be voluntarily suppressed for short periods of time. This is also the case when deliberate movement is required. In sleep, the patient is free from symptoms. Long-term studies have shown that tardive dyskinesias seldom persist for the duration of the patient's life. However, the symptoms often linger for a number of years. The risk for this form of dyskinesia appears to be particularly high in elderly patients and women. Whether other factors play a role in the development of tardive dyskinesia is a subject of some controversy. So far, none of these criteria has proven to be a clear risk factor. Anticholinergics probably do not play a role in the appearance of tardive dyskinesia. At the first signs of tardive dyskinesia, the recommended therapeutic measure is to gradually reduce the neuroleptic dose. If this is not possible, then a neuroleptic with a smaller EPS risk, a so-called atypical neuroleptic, should be administered. Tardive dyskinesia is often exacerbated by anticholinergic therapy. This effect is fortunately reversible. If Parkinsonism-like symptoms are observed in addition to tardive dyskinesia, then an anticholinergic agent such as biperidine may be indicated. Anticholinergics are particularly effective where the hyperkinesias manifest as tremor in the orofacial region, as in the rabbit syndrome. This syndrome is often accompanied by Parkinsonism-like symptoms. The rabbit syndrome should in fact not be considered a form of tardive dyskinesia, but seen as a special form of a neuroleptic-induced Parkinsonian syndrome. Although drug-induced, the Parkinsonian syndrome still displays the classic 3 symptoms: resting tremor of the hands, at times more pronounced on one side, rigidity, and akinesia. Depending on the dose and strength of the neuroleptic, at least a third of the patients displays this extrapyramidal side effect. The symptoms often manifest some days or weeks after the onset of neuroleptic therapy. The main diagnostic criterion is akinesia, a generalized poverty of movement and rigid posture. When as severe as this, the Parkinsonian syndrome is readily diagnosed. However, it is not always easy to distinguish between drug-induced akinesia and catatonic schizophrenia. What is schizophrenic stupor and what is neuroleptic-induced poverty of movement? Here we have an extrapyramidal disorder. The evidence was obtained empirically by giving an anticholinergic. When the inhibition is related to psychosis, the anticholinergic has hardly any effect on the psychomotor deficit. A complex interaction between psychopathological and motor phenomena characterizes akathisia, another neuroleptic-induced extrapyramidal syndrome. In this case, subjective restlessness accompanies incessant movement. Patients feel compelled to move continually and are unable to keep still. Often they find this so intolerable that they refuse to continue neuroleptic therapy in spite of the consequences. Trapped in a vicious circle of psychosis and akathisia, some even take their own lives. The borders between psychotic agitation and akathisia are often so blurred that the one condition is hardly distinguishable from the other. Sometimes the akathisia is masked. The motor disorder is not obvious, and the patient's main complaint is a subjective feeling of tension. If, after an anticholinergic has been given intravenously, the restlessness subsides, this is a sign that the symptoms were caused by neuroleptics. Further treatment can be given orally. If akathisia appears after a few days or weeks, anticholinergics are especially indicated. Later manifestations can be treated with beta receptor blockers and also benzodiazepines or sedative antidepressants. The neuroleptic-induced motor disorder known as dystonia is characterized by abnormal muscle tone of certain groups of muscles. In particular, those muscles of the neck and head. Due to spasms in the facial muscles, patients appear to be pulling faces. Spasms involving the tongue and throat can be so extreme as to cause dislocation of the jaw. Oculogiric crises are particularly distressful. A fixed upward gaze may persist for several hours if untreated. After a symptom-free interval lasting several days, the syndrome may recur. Dystonia is, as a rule, acute and generally occurs at the onset of neuroleptic therapy, which is why the syndrome is known as acute dystonia. In the further course of neuroleptic treatment, dystonia may appear suddenly, especially after a dose increase. The first few days after a depot injection of a neuroleptic are also critical. Some non-neuroleptics are also dopamine antagonists and can cause acute dystonia. These spasms were triggered by a single dose of metoclopramide. Opisthotonus is an extreme symptom of neuroleptic-induced dystonia. This type of spasm may be misinterpreted as hysterical arc de cercle or as meningoencephalitis, tetanus, convulsive seizure, or stroke. A distinction must be made between acute dystonia and dystonia of delayed onset, otherwise known as tardive dystonia. Tardive dystonia is often not amenable to therapy. It may manifest as retrocollis or torticollis, where the head is tilted backwards or to the side. Later, the spasm may spread to the trunk and extremities, and it is then referred to as the Pisa syndrome. It is mostly young patients who are affected by tardive dystonia. Treatment is difficult and often ineffective, although some degree of relief may be provided by anticholinergics or other agents. Conversely, anticholinergics are consistently effective against acute dystonia. This painful and unpleasant condition can be treated specifically by injecting piperidine, for example.
Ja.
Relief from the symptoms sets in rapidly. To see the symptoms disappear in a matter of minutes after a single injection is a persuasive experience, inspiring the patient's trust and confidence in the physician.